We want to get started with this program. I'm Sia Daneshmand from USC, and this is the Peer Review AUA 2025 Bladder Cancer Symposium. I am absolutely delighted to be joined by my colleagues here who are all experts in bladder cancer management, Dr. Laura Bukovina, Sarah Sutka, and Matt Galsky. Hopefully this will be a highly interactive course, and this is one of those times we really want you to participate. So there'll be cues. We usually tell folks to put their phones away. This is quite the opposite. We want your phones out because we want you to take pictures of the QR codes and, again, participate. And feel free to send in questions as well, both here and online. So we will move forward. I introduced the panelists. I really want to thank PeerView and Beacon for providing this session, and AstraZeneca, Daiichi Sankyo, Ferring, and Janssen for providing the educational grants for this symposium. Without them, these kind of symposiums really doesn't happen, so thank you very much. So if you haven't done it already, please complete the pre-event survey and then look out for additional polling, again, like I said, during the presentations. So have your phones on the table so that you can quickly take a picture of the big QR codes and submit your questions. Now, for the in-room learners, you can use your personal device, like I said, and the virtual ones, you can respond to the polls on your screen. So here's the first one. We have a reward at the end for answering questions. So take a photo of this or the QR code. I'll give you a chance to do that. And there's a chance to win a $50 gift card provided by PeerView by answering polls, submitting questions to the faculty, and we'll announce the winners at the end of this session. So if you're a healthcare provider, you'll see a green winner message that will appear on your mobile device at the end of the session. And you can see one of the PeerView staff members to claim your prize. Okay, and you can visit us at peerview.com/bladder2025, view the slides and practice aids, and download them after the event. So all these slides will be available. So there's a lot of data we're going to be presenting, and you don't have to look at every table. We're going to do more of a higher level overview of these studies, so that and you can of course go back to the slides if you're interested in looking at this. All right, so again, I'm Sia Daneshmand. I'm a urologist at USC, Director of Urologic Oncology, and I really want to welcome everybody here. The goals for today are to augment your knowledge. Bladder cancer is a very fast-moving field right now. We want to show you what's out there, what's new, some of the safety data for the modern treatment, and give you the skills to incorporate these regimens into your practice, and provide you maybe some guidance, and again, have some interactive discussion, both with the panel as well as with the audience. Okay, this is your first question. This is a test. Let's see how many people can do this. All right, as we get started, let's answer a question about challenges in your treatment decision-making. So please take a picture of this, or get to the appropriate website. Give folks just a little bit of time. All right. Okay. Hopefully you've had time to answer that question. So I want to mention Beacon. This is an incredible resource for patients, professionals, and caregivers. These brochures are available to you. It provides all from A to Z, everything you want to know about bladder cancer from a patient perspective. It has resources available for patients. So I always bring this pamphlet into the consult room with the patient. It has really easy to read pictures, and so it's really a wonderful resource. And it's not just that. There are printed materials, there's animated videos, there's webinars, podcast, treatment matrix. It's really an incredible resource. This is what we've really been looking for, one-stop shop for bladder cancer management. So now please either download the resource that's available or order these pamphlets in your clinic, whether you do a little bit of bladder cancer or you do it every day like I do and the whole panel does here. I think that this is really an incredible resource. And they have it in Spanish as well. And Stephanie's here from Beacon, and you can talk to them about more details about this. All right, so there are a lot of unmet needs within the disease spectrum. Many of the patients who receive intravesical BCG become unresponsive to BCG, so we want to go over some of the newer treatments that are available. So many of the patients with muscle-invasive bladder cancer do not receive any curative intent surgery or therapy, for that matter. And many of the patients who undergo radical cystectomy for muscle-invasive bladder cancer have some impaired health-related quality of life and high risk of recurrence. So we'll talk about what else we can do to mitigate those risks. And many patients with metastatic urothelial carcinoma may not even receive the first-line systemic therapy, let alone the later lines of therapy. So we're going to talk about the entire spectrum of disease. There's going to be a lot of information. Hopefully some of it is new to you, and some of it you'll already be familiar with. So we want to develop safe, effective, durable intravesical treatments. And again, we'll go over the current treatment available options for you, both FDA approved as well as some in clinical development. Effective approaches, post-radical cystectomy, and strategies for treatment sequencing after metastatic progression, and some clinical trial opportunities for patients and how they can reach those treatments. Okay, there are lots of different risk categories and risk groups. This is the one we use. Of course, we use the AUA one as well. But I just want to kind of highlight the high-risk patients. This is for non-muscle invasive. This is the IBCG, International Bladder Cancer Group, risk categories. That's very similar to the EAU or the European guidelines as well as the AUA. So any patient with any high-grade disease, high-grade TA, T1 CIS, any T1, of course, is considered high risk. Progression is the main concern because these patients have a variable chance of progression. So there's up to 30% chance of progression and a very, very high risk of recurrence. So this is the very first thing you want to tell the patients, that once they're diagnosed with a high-risk non-muscle invasive bladder cancer, that the recurrence rates are high, so they're not surprised when you see them at 3 months, 6 months, and thereafter, and they have a recurrence there. So the definition of BCG-unresponsive disease is at least one of the following. If you have persistent or recurrent CIS, with or without papillary disease, within that first year of completion of adequate BCG, and adequate BCG is getting at least the induction, 5 of 6 of the induction, and 2 of the 3 of 1 maintenance courses. So just think of the 5 + 2 as the minimum required to meet this definition. And these definitions exist because when we put patients into clinical trials, we need to meet these definitions for FDA, per the FDA guidance. Any patient who has recurrent high-grade or TA or T1 within 6 months of adequate BCG, and of course anyone who progresses to high-grade T1 at first evaluation. So any progression, of course, is considered BCG unresponsive. So we don't recommend using further BCG when you've already gone to T1 disease. So this is just a snapshot, and Dr. Bukovina will go through this in a little bit more detail, but we have several FDA-approved therapies and then lots of other therapies under investigation, which are very, very exciting. We have all the TAR-200 device, sustained release gemcitabine in various clinical trials, the Sunrise 1 through 5 program, so there's 1, 2, 3, 4, 5. Now, Sunrise 1, 3, and 5 are in non-muscle invasive disease. Sunrise 2 and 4 are in muscle invasive disease. Then we have some targeted therapies with FGFR3 inhibition and the sustained release of erdafitinib. We'll talk a little bit about that. And oncolytic adenovirus like cretostimogene grenadenorepvec, and talk about that. So with that, I will hand it over to Dr. Bukovina to hear about the new therapies.
Thank you so much, and welcome everyone. If anyone's looking for seats, there's some in the front. And thank you for having me, and I really look forward to talking about where we were, where we are now, so that way we have an understanding of where we need to go next. So my focus today is just to talk about what the current therapy, what's the current guidelines and FDA-approved medications that are available for patients with high risk and BCG-unresponsive non-muscle invasive bladder cancer. So if we didn't mention gemdosi, and it's not FDA approved because of lack of level 1 data, I think we would be missing a huge chunk of what's currently being done in the community. And intravesical gemcitabine really has become the standard and sort of the de facto standard for care in the BCG-unresponsive disease without level 1 evidence. However, we have multiple other potential therapies that are equivalent, or potentially logistically even better down the pipeline. So just before we head on into other therapies, making sure we recognize the player that's out in the community and many academic centers. And that's really, many of us are really anxiously waiting at the prospective data for the BRIDGE trial, which focuses in the high-risk BCG-naive cohort, and that's being run out of Hopkins with Dr. Cates. And again, this really focuses on the combination intravesical therapy of gemcitabine compared to BCG and SWOG protocols. So not a lot of data currently available in the prospective setting, but certainly something that many of us are looking forward to. Now, moving on, sort of going back to where we were before, BCG-unresponsive disease, not a lot of therapy that was available over the last couple of years until we really got the results of KEYNOTE-067. And many of you know KEYNOTE-067 was really focused on the use of systemic pembrolizumab in the setting of high-risk non-muscle invasive BCG-unresponsive disease, which gained approval in January of 2020. And again, we have 5 years of data based on just the FDA approval 5 years ago. Now, what's important to understand is many of these FDA-approved treatment, it's very difficult to compare cross-trial because the definition of complete response is very different going back 5 years to what we have now that's dictated by FDA. So every CR that I do show today, just take that with a grain of salt that the CR is differently described in many different studies. So try not to do too much cross-trial comparison. So in terms of the CR from the KEYNOTE-057, we see that there was a 40% response, and durability of that response at 12 months was 23%. Now, what's important is that, yes, potentially this is different than what we are currently seeing in the novel therapies, but this was the first available treatment, and this was the first available treatment available for patients who really had not many options available except cystectomy. It was also the first time we saw as urologists systemic side effects, which we're not used to within many intravesical therapies. And the chances of grade 3 toxicity were anywhere between 5 and 10%, with many are what's called life-altering toxicity, including thyroid issues. Although many of these resolved with discontinuation of treatment, it opened up a urology world to systemic treatment for BCG-unresponsive disease, and really paved the way for us to see that, yes, even though it's unresponsive, there's still potential options available for patients to spare their bladder. And that's the goal, is the cystectomy-free survival in these patients. And again, the systemic therapy, again, opened up the world to many ongoing trials within combination approaches, including both BCG-unresponsive and BCG-naive space. So a couple of the highlighted ones, I mean, many available, include the phase 3 POTOMAC trial, which includes BCG induction plus durva, comparing with maintenance versus no maintenance therapy. And of course, KEYNOTE-676, which looks at BCG plus pembrolizumab compared to BCG standard of care. And I think a lot of us were also excited about the ADAPT trial, which was recently presented at GU ASCO, looking at combination of, instead of BCG, combination with gemcitabine docetaxel. And the CR rate here reported at 24 out of 27 patients at 3 months of 87% is the combination of durva plus gemcitabine in the BCG unresponsive. Now, we don't have long-term follow-up data. We know that a lot of times durability is the issue here, but just shows you that there are a lot of systemic therapy that's being initiated within these trials. And moving on to nadofaragene, I think one of the first gene therapy approved by FDA for treatment of BCG-unresponsive disease, an incredibly unique mechanism of action by essentially hijacking the urothelial machinery to produce interferon gamma, stimulating not only the cytotoxic and cell-killing ability, but also immunomodulatory ability. And beautiful work done for decades to get to this part. What it's showing is within the cohort of CIS plus or minus papillary disease patients, which we typically consider to be our higher risk cohort, the CR at 3 months was 53%, which is incredible for many of these patients who really had no other choice. And durable response at 12 months. In addition, if you look at the long-term follow-up data that was reported at 5 years, we know that there's an ongoing response. While many of the patients potentially do have low-grade or high-grade recurrences, what I think is very interesting to highlight is unlike our BCG data and reinduction data in the BCG-unresponsive cohort, where the progression is as high as 15–20%, we are really seeing that not many of these patients progress to muscle-invasive disease and are able to spare their bladder. So it's not change, it's changing sort of the paradigm of what's actually happening in the progression, and that's what's important for patients. The cystectomy-free survival at 5 years is 43% of these patients, and that's an important criteria to mention to your patients in clinic. So yes, while recurrences might happen, the chances of saving your bladder is very high at 5 years. Similar to many intravesical therapies, we see toxicity that is pretty much limited to the bladder. In addition, there are some grade 3 toxicities, but that number is very low. So that's one of the additional benefits of intravesical therapy, really limiting the systemic toxicity events. Based on very successful data from nadofaragene, there are multiple ongoing trials that they're exploring combination therapy, so comparing to nadofaragene alone versus combination with gemcitabine docetaxel. Again, taking into consideration what's actually happening into the community, listening to what people are doing in the community, and incorporating the available therapies that we have. In addition, phase 3, ABLE-32, is looking at the intermediate risk group, which is, we know is sort of a hodgepodge of everything from TA high grade to low grade recurrences. And I think one of the most interesting trials within this space is really looking at the physician and patient and caregiver surveys that are being done as part of phase 4 ABLE-41. So not only are we providing the therapy as standard of care, this trial really looks to see what the feedback is in terms of patient anxiety, caregiver anxiety, in addition to CR defined as by the community. Many of us are urologists. We're not going to be biopsying patients every 3 months. That's not what CR is in our clinical setting. So really incorporating real-world experience into use of this medication. So really looking forward to results of this. Moving on to IL-15 superagonist, nodapendic and alpha. I'm not going to say that again. We'll call it NAI. But looking at, again, a very novel drug, it's an immunostimulatory drug. So it works by incorporating an antibody that binds to an NK cell receptor, and this actual binding is prolonged because it's a mutant. It's essentially a mutant of an IL-15, so it's able to stay at the receptor for a prolonged period of time and really hyperstimulate NK cells. The NK cell stimulation becomes cytotoxic, killing cancer cells, but also causes proliferation of T cell and NK cells, and essentially stimulating. So instead of removing the brakes that we see in PD-L1 on the immune system, it's actually pushing on the pedal and really making the immune system go much faster. Quilt-3, which was reported out, had a remarkable response in BCG-unresponsive disease. Again, the response was over 71%, a complete response was reported as 71%, with durability of response noted at 26 months. In addition, when we looked at 2 years, 53% were able to get a CR with durable response. There's also updated data following 2.5 and I think 24 months data looking at the prolonged response. And again, the CR at 24 months was 53%. So while it works, in addition to that, it also works well, and there's a durability to that. Based on this, so again, moving into a different disease space, so based on the BCG unresponsive disease, now we're moving into the space where we're looking at high-risk BCG naive cohort. And this study is ongoing, and this looks at BCG naive cohort combination with NAI plus BCG versus BCG alone, and this is actively recruiting. Now, similar Intravesical delivery side effect profile is limited in terms of grade 3 toxicity. Much of it is limited to the urinary tract in terms of dysuria. Very tolerable for most patients. And just wanted to make sure that many of us and many of our patients are aware that BCAN has tons of helpful resources for patients. I use this in my clinic. We have the books on my wall. Patients really appreciate having patient-centered information delivered in a very easy way to understand this data. Oh, sorry, that's you.
Okay, so we're going to discuss a case here. This is going to be for the panel. We have a 75-year-old non-muscle invasive bladder cancer. ECOG status is 1, so some medical comorbidities. CIS and high-grade TA. Patient's BCG unresponsive, undergoes repeat TURBT. There's no residual tumor. Patient has arthritis and lives fairly far away from the clinic. So for the panel, let's start with Matt, because he's falling asleep over there. Systemic immune checkpoint blockade with Pembro. Is that something you use?
So it's something that we use once in a while, of course, for the right patient. It's the right treatment. This patient has a history of arthritis. We don't know if it's an autoimmune disease or not. That would matter. That could be a relative contraindication to giving systemic immune checkpoint blockade. The results with Pembro in BCG-unresponsive non-muscle invasive bladder cancer, I think, those results are often dismissed as not as good as expected. I would argue that that durable response rate with immune checkpoint blockade is consistent with what we see pretty much across every clinical disease state of bladder cancer. About 20 to 30% of patients benefit, and when they benefit a really long time. And so it's the right treatment for the right patient. This patient lives far away. IV Pembro is given every 3 weeks. There's a risk for systemic side effects. If he lives far away, then you're worried about him getting systemic side effects locally, and who's going to manage those. So all of those need to be balanced.
Okay, Sarah, patient comes to see you, heard Matt, but he's kind of afraid of the systemic side effects still, despite his charm. So we're going to go to you. What do you think about Gemdosi in this setting?
Well, I think before you have to take a bit of a step back and understand a little bit more about this patient. So after the BCG, what is the bladder function at this point? How much toxicity did that patient sustain by having the BCG? Do they have a lot of urgency and frequency, nighttime urination that's interfering with their quality of life? That matters because you've got to think about sort of what additive toxicity they're going to be able to tolerate. Because at the end of the day, if we can't get the drug into the bladder and allow the drug to be maintained, I mean, the Gemdosi paradigm is predicated upon allowing the hour dwell of each drug. And that sometimes can be hard for a patient who has a lot of toxicity from the therapies they've had before. However, there are benefits to Gemdosi. It is much more cost effective. It's something that is widely available. So I think that there are, as these new agents hit market and have FDA approval, that's beneficial, but not all clinics have access to them. So ultimately, you need to see what do you have available, and then what is this patient able to tolerate. The other thing I will just say, though, is that, of course, with Gemdosi, you're talking about a treatment a week for 6 weeks, followed by monthly maintenance if the patient travels far, and especially we know that our older patients often have issues around access to care and issues around access to transportation that may be prohibitive. So I think you have to ultimately have that conversation, because that really sort of, I have a feeling Dr. Bukovina is going to get to comment on the benefits of potentially utilizing nadofaragene in this situation where a lot of the patient-specific factors may favor sort of a lower treatment burden option.
All right, so good segue. The patient lives in Los Angeles, known for its mild traffic, and it's a little difficult. The patient hates the parking at USC and is asking about nadofaragene for Adenavec, can pronounce it really easily. What do you think?
I have to agree with Sarah. I mean, this is a very common patient that we see in clinic coming from somewhere far away, perhaps not the healthiest, has comorbidities. And I think one of the other things that we didn't mention here is they probably would also potentially be offered reinduction and cystectomy, right? So those two things are not offered on this list, but we potentially can discuss them. And I always focus on patient's bladder, how they had BCG, how they tolerated it. And then I also focus on patient comfort. A lot of these patients will prefer nadofaragene just because of ease. once, they come back in 3 months. And then the gemcitabine, I do like it if they're able to get it in the community. So a lot of times we'll work with our community providers and finding clinics that can provide this for patients in the community, as long as the patient understands that this is a very similar cycle to BCG. And a lot of patients say, I really just don't want a catheter every week. I really don't want to have to spend hours in clinic. The whole process is about 4 hours. So while it's 1 hour installation into the bladder, it's 2 plus additional nursing time. So that's 4 hours out of the day for gemdosi that a patient has to take out. So it really just depends on that patient.
Can I just get a quick poll from the audience? How many of you are using gemcitabine docetaxel sequential therapy in your practices? Quick raise of hands. So despite this being a very common, I'm seeing less than 10% uptake in most settings. So of course, nogopendekin that you mentioned has excellent 2-year results available as well, and that's also available. However, it has to be given with BCG, and there are some challenges with BCG shortage in some areas. So the company's actually been very helpful in trying to provide recombinant BCG. That's a new thing. So I think ideal choice is really dependent on the patient from what I'm hearing. All three of these are options. I do have an audience question, and a good one, which is, can you retreat with nadofaragene firadenovec if the patient has a recurrence? So let's take it back to Sarah. Do you do reinduction, nadofaragene?
So I personally have not yet, but I think we actually only had it on formulary for about a year, so I haven't been faced with that. I think there is some data around reinduction, and we'll start to see that data mature coming forward. I'm not sure if you have experience with that.
Yeah, Laura, you mentioned the ABLE-41, the registry trial, and part of that is actually collecting data on patients who are getting reinduction, right?
Yeah.
Are you using it in your clinic?
As long as it's not upstaging of disease. So in this patient who came with TA, let's say they have high-grade TA, CIS, and then 3 months later they have TA high-grade, I would consider reinduction. However, if there's a T1 involvement or diffuse CIS, then I would be concerned about reinduction. But certainly if there's no progression of disease, it's very reasonable to do.
Certainly, and we are using it as well. It makes sense. It wasn't done in the original clinical trial, but certainly makes sense from its mechanism of action. So with that, we're going to move on to the next part of this. Patient perspectives are important. Again, Beacon can be an extremely valuable resource for both patients and providers. And you should really try to participate in all activities if you're treating bladder cancer that Beacon offers. So we'll move on, and please answer this one question. So get out your phones again and take a, this will take you directly to the question. We're not going to see the answers, so just to answer the question real quick. Okay, so we're going to move on, and we're going to go to Dr. Sutka to talk about the therapeutic innovations in non-muscle invasive bladder cancer.
So thank you very much, Sia. I'm truly grateful to be able to be here today, and I think this is just an incredibly exciting moment in time. So you've already heard about how quickly the landscape has changed in high-risk BCG-unresponsive non-muscle invasive bladder cancer. I just take a step back. If you were having this conversation 5 years ago, there really weren't great options available. The options for those patients who have cancer, non-muscle invasive bladder cancer that comes back after BCG, we were having conversations around cystectomy. So you've already heard about what current agents are FDA approved that have really moved this landscape forward. I want to highlight a couple of agents you're going to be hearing a lot about in the coming year. I think that this is going to be a year where you're going to see that FDA approved list grow even further, and I hope that you can just take home a couple of nuggets of information here that will allow you to be prepared for these newer drugs that are going to be hopefully coming to your formularies shortly. So this is a drug called cretostimogene that is another oncolytic adenovirus. This is distinct from nadofaragene, which is a non-replicated virus. This is an adenovirus that is actually ultimately taken up within the bladder cancer tumor cell and replicated within the tumor cell. And there's a dual mechanism of action. So first of all, The drug is ultimately transcribed within the cancer cell, and that's toxic to the tumor. In doing so, you basically turn the bladder cancer cell into a bioreactor. So it starts to replicate more of the drug, and then you have this kind of ongoing cycle that creates a chain reaction where you create more drug, the drug kills the tumor cell, that it transfects other tumor cells, and so on and so forth. But as the tumor cells die and release not only the drug, but also all of their cellular contents into the surrounding environment, you actually stimulate an anti-tumor immune response. So you have this dual mechanism of action that appears to be very successful. The original data that supported the efficacy of this strategy was the phase 2 CORE-001 trial, which was a single-arm study that combined cretostimogene with pembrolizumab, and it had a 54% CR rate at the 24-month landmark. Now, this paved the way for the phase 3 BOND-3 trial, which most of you will likely have heard of. This was presented by Mark Tyson. The eligibility criteria here is that you have pathologically confirmed high-risk BCG-unresponsive non-muscle invasive bladder cancer. Just to get specific here, this is the FDA-approved definition, so patients who have been exposed to either 5 of the first induction doses of BCG with an additional 2 of 3 of the maintenance doses, or they can have received 2 in sequential induction doses. These are patients who have had all of their disease visibly resected, and there is a mandatory confirmatory biopsy at the 12-month assessment. The primary endpoint is the complete response at any time. So cretostimogene is given very similarly to a lot of the other intravesical therapies that we have heard about. There is an extra step. There's a wash step with an initial drug that is used to basically improve the bioavailability of the drug to the urothelium and the treatment effect. But essentially, the drug is instilled weekly for 6 weeks in a row. A second induction for non-responders is permitted under this trial concept. And then the maintenance is given similar to what we do with BCG, thrice weekly, every 3 months for the first year, and then every 6 months for the second year. And here's the top line sort of results. So the CR was 74.5%. So we're really seeing this sort of moving of the needle to what is going to be the new benchmark for success in these trials, which is a complete response rate over that 70%, which is a lot of what you heard in Dr. Bukovina's, the evidence that she presented. The 12-month CR rate was 46%. So this is a durable and a sustained response. And it's, if you estimate it using the KM curve, it's about 50%. And at 2 years, there have been 25 confirmed CRs at 2 years with a 41% estimated CR rate. Now, among those patients who achieved a complete response, about 2/3 and just over half maintained the CRs, as I said, at 12 and 24 months. And the median duration of response, this is really important, the median duration of response has not yet been reached at 27 months. That really moves the needle for these patients who, unfortunately, prior to this date, we've really seen these relatively frequent responses that then become devastating and then force us all to introduce that conversation around cystectomy. And also, this is extremely well tolerated. There have been no grade 3 or greater treatment adverse related events reported thus far. And no one's had to stop treatment because of toxicity. That's also really important because we know that historically, if you just think about BCG alone and the original SWOG protocol, less than 20% of patients actually make it through all of BCG and BCG maintenance. So we're talking about a very tolerable treatment option. I want to introduce another new novel, and this is a drug device delivery system. So TAR-200, which many of you will have heard about, there were a number of very exciting discussions about this device in the plenary on Saturday. This is an intravesical drug delivery system. So it's a device that is introduced through a catheter into the bladder that essentially permits prolonged contact between the urothelium and the drug. The drug is gemcitabine. It's eluted by this device, which floats in the bladder and essentially is maintained. It is then withdrawn cystoscopically and then reintroduced with this catheter. It is very easy to place. It can be done in the clinic the same way that you would do a cystoscopy, and a lot of those of us who have been participated in the trials, many of us are utilizing. We can place it, but I think there's going to be opportunities for advanced practice providers to learn how to do this. The device is well tolerated by the patient. It's not felt in the bladder during sort of day-to-day living, and there are no limitations on activity with the device. However, the side effect profile is very similar to what we see with other intravesical therapies in terms of both dysuria, as well as increasing urgency and frequency. So this is the study schema for Sunrise-4. This was a randomized controlled trial, randomized 2 to 1 to 1, between the TAR-200 device with an IO agent, the citralumab, compared to TAR-200 alone, compared to citralumab alone. Now, I'm going to focus on that cohort 2, which is the TAR-200 alone, because that's where the majority of our I would think is sort of the implications for our community comes. And then there is a second cohort. There's another cohort 4 that was specifically looking at patients who did not have CIS, who had papillary-only BCG-unresponsive non-muscle invasive bladder cancer, and there was an update report on that cohort here at this meeting. This device is placed for 3 weeks at a time for the first 24 weeks, and then it's replaced every 3 months or every 12 weeks through week 96. And the endpoint of interest for Sunrise-4 is your overall CR rate. In cohort 4, where you're looking at that papillary-only recurrence cohort, it's DFS at 12 months. And here's the top-line evidence. This is what you need to take home. The complete response rate, whether it was centrally assessed or investigator assessed, was greater than 80% among those patients with high-risk non-muscle invasive CIS with or without papillary disease, with 6 and 12-month durability of response rates of 93 and 84%. That's I think very encouraging data. This drug device delivery system has achieved FDA breakthrough therapy designation, and you're going to be hearing quite a bit about this in the coming, I would say, year. This is the centrally assessed complete response rate at any time. Again, pay attention to the middle bar, the dark blue bar. That's the TAR-200 monotherapy cohort 2 arm. And again, just highlighting the fact, so the overall complete response rate here is 83%, and you see that the 12-month duration of response is seen in about 2/3 of all patients. So again, that's very encouraging. The median follow-up thus far is relatively short. We acknowledge that, and we're looking forward to seeing more data here. The patients remaining in response at that time is 82 of the 85. Many of you will have also heard the updated report by Dr. Felix Guerrero-Ramos in the plenary on Saturday. This was that cohort 4. So these are the patients who do not have CIS. They have papillary-only disease who received TAR-200. And I think what I'd hope that you will take home here is that the event-free survival at 6 months is 85% in that cohort. So then these are patients, again, with TA, T1, high-grade disease, non-muscle, BCG-unresponsive. The 9-month DFS rate is 81%. Only 3 of the 52 patients in that cohort 4 have undergone radical cystectomy, so the vast majority of them have been able to preserve their bladders, which is critical. And we see these consistently high DFS rates across the different strata that were evaluated. Here you can see the progression-free survival data as well as the overall survival data. I think the progression-free survival data here is probably the relevant point of interest with a 9-month PFS, because remember how common progression is in patients with BCG-unresponsive non-muscle invasive bladder cancer. So the 9-month PFS rate here is 96%. And as I said, in general, this device is relatively well tolerated. I have personal experience utilizing it in some of the trials. I think that classically we see the types of side effects that we as urologists are very comfortable managing in terms of urinary frequency, urgency, bladder spasms. There's going to be a paper that's going to be published in the coming months that you'll see that actually gives actionable strategies for how to optimally manage these side effects and prophylax against them. Big points, I think, that make it very, that help to basically optimize the likelihood that a patient is not going to have severe side effects include things like encouraging them to be very well hydrated and prophylaxing with antispasmodics prior to device placement. In terms of when you see these side effects, they are most commonly at the beginning of each 3-week placement period, and they sort of, I would say, degrade thereafter. But very few patients had to have the device removed because of any of these side effects, and there have been no treatment-related deaths. This device is being evaluated in multiple other non-muscle invasive bladder spaces. So this is the phase 3 Sunrise, the phase 3 Sunrise 3 study. So we were just talking about BCG-unresponsive non-muscle invasive bladder cancer. This is in the BCG-naive space. This is a fully accrued randomized trial, over 1,000 patients. It is comparing TAR-200 with citralumab to BCG to TAR-200 monotherapy, and the primary endpoint is event-free survival. Sunrise 5 is going to look at those patients who have recurrent papillary disease without CIS. And it's going to compare TAR-200 to either intravesical gemcitabine or mitomycin, again with the objective of seeing if these patients can have their bladders spared and not force the move to a radical cystectomy. The primary endpoint here is disease-free survival. So I think there's a lot of Sunrise trials, the things that I hope you will take home. So this is a gemcitabine-eluting device that is placed in the bladder. It's held for 3 weeks at a time. And here, the Sunrise 1, 3, and 5 are looking at sort of the different spaces within the non-muscle invasive space. And we'll hear a little bit about the muscle invasive space in a moment. But we also have learned a lot in the last 10 years about the biology of bladder cancer, and specifically the biology, the genetics and genomics of this disease. One of the things we've learned is that FGFR mutations are very common in bladder cancer. The take-home point, or something that I hope you will remember, is that they're much more common in patients with non-muscle invasive bladder cancer than they are in muscle invasive. So one of the sort of, I would say, very enticing hypotheses is that we can leverage this biology and opportunistically utilize that to better increase the efficacy of our treatments. But what we do know is that genomic testing is actually relatively rare in patients with non-muscle invasive bladder cancer. This is some Flatiron data. What the sort of punchline here is that very few patients actually get genomic testing who have non-muscle invasive bladder cancer, and it's maybe something we should be thinking about doing more, because potentially we can identify those patients who are more likely to respond to drugs that we now have available to us. So let's talk about this TAR-210 device. So this is the same device in terms of what it looks like that you just saw. It's a flexible plastic device that is placed through a catheter into the bladder, but instead of eluting chemo, it's eluting erdafitinib, which is a pan-FGFR receptor inhibitor. Now what that does is it breaks down the ability of these cells to basically, all of the tyrosine kinase pathways are interrupted. And this is the first in human phase 1 trial data that evaluated in those patients who have FGFR mutations in their tumors. We are looking at whether or not this device can be utilized in both cohort 1, which was those patients with high-risk non-muscle invasive bladder cancer who were BCG exposed or BCG unresponsive. So these are the patients that are similar to what we saw in that Sunrise 1 cohort. Excitingly, though, this is, as I mentioned to you, those FGFR mutations are preferentially expressed not only in non-muscle invasive bladder cancer, but in patients with low-grade tumors. And that brings us into this space of intermediate risk disease, which we haven't talked about yet. That is non-lethal, non-muscle invasive bladder cancer that unfortunately comes back over and over and over again. It's essentially a very burdensome chronic disease. And the current pathway or paradigm for that, as you all well know, is that we take these patients to the operating room multiple times, sometimes within a year, to resect these tiny papillary low-grade recurrences and then subject them to intravesical chemotherapy. And I think that when we think about one of the key goals in the management of that disease space, it's how do we keep those patients out of the operating room? So this agent is being looked at as an ablative strategy. With tumor in situ that is intermediate risk, low-grade, TA, papillary disease, can you put a device in the bladder that kills the tumor and keeps that patient from needing to have a resection? This is the strategy for both of these two cohorts, is to utilize the first in human study looked at both of these two disease spaces, and it was also a dose escalation and dose expansion trial. High-level responses. So this is in the high-risk non-muscle invasive bladder cancer patient cohorts. We see a 90% estimated 12-month recurrence-free survival rate. That's very encouraging. The median duration of response here is just under 9 months, and there isn't any difference thus far in the two dosing strategies that were evaluated. In the intermediate risk ablative strategy trial in that cohort 3, we see that there again is a 90% CR rate. These patients did not have their tumors resected. These patients had a device placed in their bladder with the goal of ablating those tumors. And we see that 100% of patients achieve this clinical response. This is consistent across both dosing strategies, and we see that the 6 and 9 month durable response rates were 100% and 89%, and that paved the way for the phase 3 Moonrise-1 study that you're going to be hearing quite a bit about. This is comparing patients who are randomized to that TAR-210 device, the erdafitinib-eluting device that's placed in the bladder, to investigators' choice of intravesical chemotherapy, which is really our standard. And these are patients who do have FGFR mutation positivity as defined by central laboratory testing. The primary endpoint here is disease-free survival, and it's a crossover study. If patients recur, they can go on to the alternate therapy that they were not initially randomized to. Last slide here for me, I just want to show you I want to highlight two very exciting new potential therapeutics that you will be hearing much about in the coming years. So the EG70 agent is a non-viral intravesical gene therapy. This is being evaluated in the 2 Legend trials. There was a phase 1 study that demonstrated a very tolerable safety profile and a CR rate of 73% in patients with non-muscle invasive bladder cancer with CIS. And then we have a phase 2 Legend trial that is currently ongoing. Cohort 1 is BCG-unresponsive disease, and again with that 71% of patients with a CR. And then I'm sure many of you were in the plenary yesterday and heard the CREST trial data. So sasanlimab is a subcutaneous anti-PD-1 monoclonal antibody. This allows delivery of an IO-based therapy without the need or the requirement for that patient to go to an infusion center. So one of the critical, I would say, concerns or complaints that a lot of patients with non-muscle invasive bladder cancer have had regarding the receipt of pembrolizumab has been that it really changes the experience of having non-muscle invasive bladder cancer. You're taking a patient who normally would be managed in a urologist clinic and asking them to go to an infusion center where they are, at that point, surrounded by patients who are being treated for malignancies across the spectrum of disease, in many cases, metastatic disease. It's a different experience to have that be part of your treatment paradigm. Granted, there's good efficacy, and there are patients in whom that is incredibly appropriate for, but this drug delivery option allows this an IO therapy to be delivered subcutaneously within the clinic. The phase 1 trial demonstrated 21% PR and a 32% SD rate. And then, of course, the phase 3 CREST trial results were presented here. And what that demonstrated was that sasanlimab and BCG significantly improved the event-free survivals at 32% reduction in those patients with BCG-naive, high-risk non-muscle invasive bladder cancer compared to BCG alone. So lots of things coming down the pipeline, and I think a lot of exciting trials to be looking out for the results of in the coming year.
Thank you, Sarah. Really, absolutely remarkable explosion of new data, new therapies over the past 5 years alone. I think in the very near future, we're going to have so many other therapies available to our patients. And just looking at these response rates, I mean, this is absolutely remarkable. We were very used to seeing these 20, 30% response rates, and now we're looking at 50, 70, even up to high 80% response rates. So these are really fantastic. Of course, we look forward to longer-term data to see the durability of responses. So let's go to discussion now and discuss Philip. He's a 72-year-old patient, non-muscle invasive bladder cancer. His ECOG status is 0, pretty healthy. And he has CIS, high-grade TA disease, again, BCG unresponsive, and undergoes gemcitabine and docetaxel sequential therapy for 6 weeks. 6 months later, now has a recurrent papillary tumor. So what options do we have, either trial or non-trial? Let's just pretend these are available because 2 of these are fast-track FDA for approval. So let's fast forward to, let's say, next year, and Laura, tell me what you might think of this patient who's at BCG and gemdosi. What do we have?
I think this is a trick question because it's not telling us what papillary tumor.
High grade.
High grade, okay.
Yeah.
All right, so I think the way I approach this patient is they failed 2 modes of therapy. So they failed BCG and they failed gemcitabine. So if you think about on the biological sort of spectrum, whatever tumors they're getting now, very resistant, right? So you're going into the 3rd line of therapy. This is a very high-risk patient. The CIS component itself is very high risk. So I definitely would not re-challenge them with a gemcitabine-based pretzel. I definitely would not give them TAR. I think they already have innate tumor resistance to chemo. I would start thinking more about clinical trial and precision medicine. So not a standard of care, but in my practice, these patients get Signatera testing and restaging, which usually includes an MRI of the bladder and a cystoscopy with random biopsies to make sure we're not talking about upper tract disease, prostatic involvement, all those things. Granted, if this patient is just localized to high-grade TA in the bladder, I would consider more therapy that's aimed at precision. So if they're FGFR positive 210 or CG therapy, I certainly would not retrial them with chemo, gemcitabine.
Yeah. So, Sarah, 2 centimeters picked on purpose here, and we talk a lot about size of tumor and how, at least in the AUA risk categorization, would you consider this patient a high risk, or is this an intermediate risk patient?
So if you look at the AUA, and I'm just going to clarify, the recurrent is a high-grade recurrence,
Correct.
right?
It's
Okay.
a high grade.
So I personally think that when you have a high-grade papillary recurrence, you're dealing with a high-risk tumor. Now, that is not the AUA guidance. That is concordant with what the IBCG risk stratification system shows. And I do think that there's value in that, because this is a patient who has demonstrated not only refractoriness to treatment, this tumor is very highly treatment refractory. But I think at this point you really are thinking about what I would consider a high-risk recurrence. I think that there's a couple things we have to think about here. So one, you do have to have a conversation with this patient about cystectomy. Mm-hmm. It's absolutely imperative. Even if you are going to attempt another bladder-sparing option because that patient is not willing to undergo cystectomy, which is very reasonable, of course, they need to have had that discussion so that if the disease comes back again, that conversation is something they've already heard. And there's also time to start thinking about this. I do want to highlight the CYSTO study that was presented by John Gore at the plenary as well, which was a pragmatic trial looking at real-world data and the relative acceptability of radical cystectomy versus ongoing bladder-sparing treatments in those patients who are in this patient population, this scenario exactly. I think that we need to educate the patients about sort of what surgery is going to look like, and then obviously this is a patient who you would be thinking about a clinical trial in for sure.
Yeah, lots of potential options. Matt, do you encourage testing at this point? Laura mentioned ctDNA. We have some urinary tumor DNA. At least some companies looking at urinary tumor DNA and other diagnostics. What are your thoughts?
I mean, all of those diagnostics are incredibly exciting. I think the issue is that we don't know exactly what to do with the information yet. And so genomic testing, specifically looking for an FGFR3 alteration, quite reasonable, but again, if you find it probably informative from a clinical trial sort of pursuit standpoint, but not necessarily impacting your clinical practice. NCCN right now recommends genomic testing for patients with bladder cancer with muscle-invasive disease at high risk for recurrence after cystectomy. And so we also arguably don't have an indication for FGFR inhibition in that setting, but one of the reasons it's recommended is because it can take a while to get the blocks, get slides cut, sent centrally, get genomic testing. Sometimes that's a couple-month process. So you certainly want to have that information available when you need it rather than scramble to try and get it.
Thank you. So I want to go to an audience question. What can you tell us about patient involvement in these adoption of these advances in bladder cancer management approaches? I think that's very important as we offer these new options to patients and even clinical trials. So Sarah, what's your approach to showing the patients what's available to them and encouraging them to go on a clinical trial, especially as we get more and more therapies approved?
Yeah, I think that this conversation has gone from a very sort of straightforward, if this then that algorithm, to we have an embarrassment of riches. And so we need to walk through all the different options. I think, again, key factors that ultimately, I think, inform shared decision-making really critically here include a very careful assessment of what the patient's priorities are. So you've got to understand from patients, what does a successful outcome look like to them? And is that bladder intact at any cost? Avoidance of a radical cystectomy. If you have an older patient who is medically complex or has a high burden of frailty and comorbidity, the potential sort of risk of going through a radical cystectomy is a major change in the way that they live their lives. So understanding sort of what value do they place on keeping their bladder, and then also how far do they live from the hospital? What does their financial situation look like? I think that financial toxicity is obviously going to become a very important conversation point in all of this. And then what drugs do we have access to? I think clinical trials should always be discussed but we do have to break down sort of mechanism at a high level so that patients can kind of understand what are the implications of each of these therapeutics in them. And so that kind of frames the shared decision-making conversation. You got to be really honest about what risks and benefits look like. You need to understand what's the function of their bladder. Are they up all night because they're urinating all night? Are they leaking because they have urge incontinence? Or are they actually relatively doing pretty well? And then the last thing that we haven't really talked about that I think is a big question that is unanswered at this point is how many lines of therapy are too much? How many is too many? We know that with high-risk non-muscle invasive bladder cancer, and especially in the BCG-unresponsive space, especially with CIS, there is a risk of nodal metastases that are synchronous, that depending on the study that you read, it's somewhere between 6 and 9%. I personally have had a couple of patients who really did not want a radical cystectomy, who went through line after line of therapy and ultimately ended up with nodal metastases. We were able to salvage them, but in my mind, that's a never event. And we don't have predictors for who those patients are going to be. So patients do have to understand that you may miss the boat if you keep sort of accepting subsequent lines of therapy, and we don't have good guidance around how much is too much. So I think you have to be very honest about all of these different sort of competing risks and competing trade-offs. And that really is ultimately what guides the conversation.
I think that's a critical point. Exactly. We're going to have these therapies, and it's easy to go from one to the other, but sort of miss the fact that the patient has had a progression event in between these therapies, and it's critical. So, Laura, let me bring it back to you for a second. So 6 months later, we said has a recurrent papillary tumor that's 2 centimeters, but we know with blue light we're going to pick up a little bit more CIS, right? What do you think the role of blue light is, specifically in this setting, to help better stratify risk status, as Sarah just mentioned?
Yeah, incredibly important role. I think specifically with CIS component, we know blue light makes a huge difference. Because then you're dealing with a completely different situation if they have CIS. You're putting upper tracts at risk, you're putting prostatic urethra at risk, and that's what we typically see as patients go through first, second, third line of therapy. Their disease, especially with CIS, becomes upper tract problem. Then you're at risk for removal of bilateral kidneys. No one wants to be on dialysis. You're getting prostatic urethral involvement, limits options for cystectomy and neobladder reconstruction. So we all have to understand that as we're progressing through therapy and we're not using blue light to potentially diagnose CIS, we're putting that patient at risk for potentially much more morbid of a situation down the line.
So great points. We're talking about progression. We're talking about upper tract. So Sarah, I want to ask you, what is your general practice for looking at the upper tracts and doing CT scans? What is your threshold? How often do you think we should be doing it in BCG-unresponsive disease?
So I follow the AUA guidelines. I get a CT urogram or a CT IVP once a year. And obviously, when a patient comes in, though, for their surveillance cystoscopy, if their cystoscopy is negative and the cytology is positive, then you have to go looking. And you have to evaluate the prostatic urethra, and you have to evaluate the upper tract. So at that point, we go to the operating room. I do blue light in the OR. I don't have it in clinic, but I'll do blue light at that point with random biopsies. I will do barbotage from both ureters. If I have any concerns from the CTU, I'll go up and take a look and take biopsies. So I think that you have to have a high index of suspicion because that risk of upstream progression is so high in these patients, especially with multiple lines of therapy.
Right. So let's not forget, we tend to forget that these, in muscle invasive bladder cancer, we always do the imaging, but in non-muscle invasive, we want to make sure that as patients progress through the further lines of therapy, that we're assessing for lymph nodes, upper tract disease, and things like that. So I think it's overlooked. And one of the nice things about a patient being on a clinical trial is all those boxes are checked before a patient actually goes on the clinical trial. So lots of different options coming up as well with the combination therapies to see if we can improve on these results, especially at the 1 year, 2 year, and duration of response. As good as it is, we can absolutely get better. So we're going to move on, and let's have you scan this. We have another question for the audience, and remember, there's a prize at the end. So. Okay, great. So we're going to move on and talk a little bit about now muscle-invasive bladder cancer and cystectomy in general. This is a study that was done by Alex Zalata. I'm a participant in this study as well. This was published last year in Lancet Oncology. This was comparing, this is the most contemporary and largest comparison of radical cystectomy versus trimodality therapy, which is maximal resection with chemoradiation. And what we did was take three different large populations of patients from 3 different centers, USC, Toronto, and MGH, and tried to match as well as we could the patients to see how they did. And you can see those curves, radical cystectomy with or without neoadjuvant chemotherapy and TMT actually look quite similar. Meaning the surgical outcomes, similar oncological outcomes between these two therapies. So TMT is definitely one of the options for patients with muscle-invasive bladder cancer. Should be offered to all suitable candidates for muscle-invasive bladder cancer. But this is not a head-to-head comparison. This is a retrospective study, and from our center, a third of the patients who were selected for this study came from our database. So 2/3 of the patients were sort of deemed not comparable to the TMT. And those are the patients with the larger tumors, bilateral hydronephrosis, prostatic stromal invasion, and things like that. So the ideal candidate for TMT would be one who has at most unilateral hydro, no extensive CIS, and smaller tumors, and of course one that's deemed feasible to have a maximal reduction. But this should obviously be part of the discussion as well. So trimodality therapy, generally the patient, this involves the urologist, medical oncologist, and radiation oncologist, so it's a multidisciplinary approach. The urologist does a re-TUR, make sure that we completely visibly get rid of as much tumor as possible. Then the patient goes for trimodality therapy, which includes chemo, as well as radiation, obviously. But the thing to remember is that the chemotherapy does not have to be cisplatin. It can be any one of several drugs, 5-FU. We just need a potentiator for the radiation therapy. And the patient then undergoes subsequent TUR at 12 weeks and surveillance afterwards. If they don't have a complete response, and those patients should really go to salvage cystectomy at that point, because they do have a high risk of progression. Now, for those who remember the old days, 30 to 40% of patients may have not responded, so people weren't excited about TMT, but in modern data, it's more like 15% of patients who are not responding to TMT, and so the salvage cystectomy rates have gone down quite significantly. So what about IO with trimodality therapy for muscle-invasive bladder cancer? This is a SWOG study, phase 3 S1806, a randomized trial of concurrent chemoradiation plus or minus atezolizumab in localized muscle-invasive bladder cancer. So these are patients who are going for bladder-sparing approach. They're getting either concurrent CRT alone versus CRT plus atezolizumab for 9 cycles. The primary endpoint was bladder intact, event-free survival. with the secondary endpoints as you see listed there, overall survival, clinical response, and things like that. There's a lot of sort of corollaries to this. This accrued incredibly well and completed accrual on time, I think even earlier, with over 480 patients in the trial. So we're going to soon see data coming out of this. Very important contemporary study to see, A, what the current status is for TMT, and B, whether we can improve on those results with the addition of a checkpoint inhibitor. All right, so what about the perioperative morbidity and mortality of cystectomy? We've talked about this a lot over the past decade or so. A lot of patients are ineligible for neoadjuvant chemotherapy. There's a lot of patients who don't want the comorbidities that is associated, and mortality, which can be as high as 5 to 8% when you look at the 90-day follow-up for these patients. So there is a high unmet need for neoadjuvant treatments for muscle-invasive bladder cancer, and if they have a good response, for patients to potentially keep their status and maintain their overall health status, whatever that may be. So Sunrise 4, I'm going to turn to Sarah, who led this study, and tell us about Sunrise 4.
So this is another one of the studies in the Sunrise series. This is again looking at that TAR-200 device that we discussed in the non-muscle invasive section of this lecture. So this is a randomized controlled trial. It is a neoadjuvant trial for patients with muscle invasive bladder cancer who are either cisplatin ineligible or cisplatin refusing. And patients are randomized in a 5-3 fashion to TAR-200 with citralumab, so a checkpoint inhibitor, compared to citralumab monotherapy. The primary endpoint for this study is the pathologic complete response. But as Sia said, in addition to any neoadjuvant study, you need to ensure that not only you need to understand the efficacy of the agent, but we also need to understand, does that agent interact with or prevent patients from getting to the endpoint, which is getting to radical cystectomy safely and in a timely fashion. So here's the interim analysis. This is a fully accrued trial, and we will see likely the formal results within the coming, I would say, 2 years. But this is an interim analysis that was presented at ESMO last year, and then the safety analysis that we presented at EAU. Here's the punchline. The pathologic complete response rate in in cohort 1, which was TAR-200 plus citralumab, was 42%. And you can think about that in comparison to the pathologic complete response rates that we classically see with neoadjuvant cisplatin-based chemotherapy, which is somewhere in the mid-20s to high 30s, depending on the study that you read. And that compares to the citralumab monotherapy arm, where it was 23%. You'll see the pathologic complete response rates across different strata of the patients in the study. In patients with T2 disease, it was 48%. Patients with more advanced disease, obviously, it's lower. And we also stratified by patients who had complete and incomplete TURBT. The safety profile is encouraging. The vast majority of the treatment-related adverse events were very similar to what we see in those patients who received TAR-200 in the non-muscle invasive space. They were grade 1 to 2 urinary events that were very manageable with the strategies that we all utilize all of the time. And importantly, ECOG performance status and other performance measures did not substantially decline in that neoadjuvant period. We did not see a major delay to radical cystectomy. Across both cohorts, the time from initiation of that neoadjuvant treatment to getting to cystectomy was 13.5 weeks, and 84% of the patients were able to get cystectomy within the trial's pre-specified window of time. And there was only one patient actually who had a delay to surgery because of a treatment-related adverse event, and that was a patient who was receiving citralumab monotherapy. You can see the morbidity below. There were no mortalities related to the device in the TAR-200 plus citralumab arm. So again, we look forward to the final results of this trial. It is an encouraging potential strategy that we might be able to consider in the future for those patients who want to get neoadjuvant therapy prior to radical cystectomy but are cisplatin ineligible or cisplatin refusing.
Great, thanks. So you can see the use of TAR-200 across the spectrum of disease, from non-muscle invasive to potentially even muscle invasive disease. So Matt, you've been pretty quiet over there. We want to hear from you. Let's talk a little bit about muscle invasive bladder cancer and advances in metastatic urothelial carcinoma.
All right, thank you. I learned a lot from all of you this morning so far. So we know that path CRs happen, as we've heard, in about 30 to 40% of patients treated with TURBT plus neoadjuvant chemotherapy followed by cystectomy. And that's great. When we see path CR, we get really excited. That correlates with longer-term favorable outcomes. But it really does beg the question, if there was indeed a path CR, did the bladder need to come out in the first place? And this isn't a new question. This question has been asked for 30 plus years. Harry Herr, in 1998, published long-term follow-up from initial patients treated with MVAC chemotherapy after TURBT who declined cystectomy, showing that a large subset of those patients 15 years later had durable bladder intact disease-free survival. So we've known this for some time, so why don't we do this on a daily basis? And one of the reasons that we don't do it is because we don't have prospective studies and because it's really hard to determine who those patients are. And of course, we get quite nervous, rightly so, with muscle-invasive bladder cancer because this is an aggressive malignancy. So our group and a few other groups several years ago started to try and think about this again and try and approach it in a more systemic fashion. And we asked the question prospectively, could we give chemotherapy after TURBT, really try and rigorously assess response to treatment clinically and determine whether or not patients indeed had to have their bladders removed. So this is one such study where we did this, gave gemcitabine and cisplatin plus PD-1 blockade as the neoadjuvant therapy. If patients had what we defined stringently as a clinical complete response, they didn't have to have their bladders removed. 43% of patients achieved a clinical complete response. And you can see in those swimmer's lane plots, the dark blue lanes indicate patients who are alive with an intact bladder, no evidence of recurrence. The lighter blue lanes indicate patients who had local recurrence in yellow, followed by cystectomy in green. So one, we think this is achievable in a subset of patients. Two, we think that the majority of patients will develop local recurrence, which ideally is quote unquote salvageable with cystectomy before they develop metastatic recurrence. But this is not to try at home. This is one phase 2 single-arm study. We have some others that are emerging. The group from Fox Chase has been pursuing a variation on this theme as well. They did a series of 2 studies. The variation is that they identified patients eligible to retain their bladders based on both clinical criteria and genomic criteria. You could see in their Retain 1 study, the percentage of patients on active surveillance who remained metastases-free at the median duration of follow-up listed on the table is 64% in the first study, not as high as we would want that to be. But when they added immune checkpoint blockade in the second study, was 82% with a little bit shorter follow-up. That tells us that the immune checkpoint blockade is probably important in this setting, but of course we need more data. There's actually a phase 2/3 randomized study just getting up and running in Canada to try and definitively address whether or not we should be doing this. And then a number of novel approaches, variation on this theme as well. Those studies were started really before immune checkpoint blockade was a standard treatment in the neoadjuvant setting for bladder cancer, sort of in parallel with the big phase 3 studies that were testing that concept. And now we actually have one of those studies that's read out in the past year, the phase 3 Niagara study. And this study compared standard of care neoadjuvant gemcitabine and cisplatin followed by cystectomy versus gemcitabine and cisplatin with the PD-L1 inhibitor durvalumab given for 4 cycles, then cystectomy, then an additional 8 cycles of durvalumab. And this study met its primary endpoint, showing an improvement in event-free survival, but actually also showed a survival benefit at the time of the first analysis, which was really quite important finding given what we've seen with the adjuvant studies with immune checkpoint blockade, which have taken longer to show a survival benefit. Here's the baseline characteristics. And the 2 things that I want to point out to you just from a daily practice basis is one, this trial allowed patients to enroll with a creatinine clearance down to 40 using sort of a variation in the way that we give cisplatin, giving half of it the first week and half of it the second week. So those patients who you typically didn't send to medical oncologists because their creatinine was a little bit high and you thought they might be cisplatin ineligible, That doesn't completely apply now with these new data. The second is that patients were able to enroll in this study if they had urothelial cancer with any percentage of variant histology. Didn't matter how much variant histology there was, so very flexible design in terms of the eligibility, with important implications, because we all get these path reports showing 60% sarcomatoid variant, don't really know what to do in that setting. So this provides some comfort in terms of our standard neoadjuvant paradigms. Here's the event-free survival data showing an improvement in event-free survival with gem-cis-durva neoadjuvant, then continued adjuvant durva versus the standard treatment. Secondary endpoints all went in the same direction: disease-specific survival, overall survival, all favoring the combination therapy. And this has now become a standard frontline treatment for muscle-invasive bladder cancer in the neoadjuvant setting. And there will be some updates from this data set looking at DFS data at AUA presented by Josh Meeks. Here's the path CR rate data. And the path CR rate data has been shown a couple times, and it's a little bit confusing because there were a lot of cystectomies that weren't included in the first analysis because there was a certain date cutoff. Long story short, there's about a 10% higher path CR rate with gem-cis-durva at 37% compared to the comparator at 27%. The other nuance of this data set was this analysis was an intent to treat analysis. So a lot of our historical studies quoting path CR rates only look at patients who got to surgery. And that's a little bit cheating because that excludes the denominator of patients who never made it to surgery for various reasons. So that's why the path CR rates look a little bit lower on the study than we're used to seeing. It's because it's a pretty stringent definition, and we'll have to think about that as we compare across data sets when more of these studies read out. The other thing that I want to point out about Niagara is that there was an exploratory analysis looking at the impact of path CR on outcomes. And so this is really the first data set that we've been able to do this because we have very few phase 3 studies in bladder cancer in the neoadjuvant setting comparing one drug regimen with another. We have some studies looking at drug treatment versus straight to cystectomy, but not one drug treatment versus another. And that's actually the data that you need to ask this question, which is, do only patients with path CR benefit from systemic therapy? We hear this all the time, that it's only the patients who achieve a path CR who benefit. It doesn't completely make sense to me as a medical oncologist. We know that there's a continuous spectrum of responses to treatment in the metastatic setting, and you can have a major reduction in volume of tumor without complete eradication. And I think these data speak to this. So basically what I'm showing you here is the top curve are the patients who had a path CR with the durvalumab arm in blue compared to the standard arm in orange. And then the patients who didn't have a path CR in the bottom two curves, you can see that the blue curves are above the orange curves in both settings, meaning that there's some benefit to the addition of immune checkpoint blockade, even if you don't have a path CR. Here's the adverse event profile from the study. And most of the grade 3 and 4 adverse events on this study are driven by the chemotherapy part. You can see most of them are nausea, cytopenia, et cetera. Most of that's chemotherapy related. What we see with immune checkpoint blockade is we see lower likelihood of side effects from immune checkpoint blockade. They tend to be grade 1 or 2. The grade 3 or 4 side effects, which are uncommon, can be certainly important and life impacting, but those events aren't all that common, and you can see that on this slide. So 21% of patients developed an immune-related adverse event on this study. You can see thyroid events account for a big bulk of those. We know that a good subset of our patients will experience hypothyroidism treated with immune checkpoint blockade. Those side effects that we worry about a little bit more, pneumonitis, colitis, you see pretty uncommon in this data set. In the adjuvant setting, those studies read out before these neoadjuvant studies. We know that if you have a patient who undergoes cystectomy and has path T3 or higher disease in their surgical specimen, or had neoadjuvant chemotherapy and has pathological T2 or higher disease in their specimen, the addition of adjuvant therapy with nivolumab improves disease-free survival. led to an FDA approval in that indication. We know that the Ambassador study with pembrolizumab showed the same thing. And so in that setting, adjuvant treatment with immune checkpoint blockade is a standard treatment now. So I'll ask that you answer this question as we move on to speak a little bit about metastatic urothelial cancer. Okay. I'm going to spend the next few minutes finishing up with metastatic urothelial cancer. Many of you might not encounter this on a daily basis in terms of your own clinical care, but of course important to know about the therapies that are emerging in metastatic disease, because those will be the treatments that we're using in the clinically localized setting, high-risk muscle-invasive disease in the not-too-distant future. So in metastatic urothelial cancer, the big developments have been the addition of immune checkpoint blockade, and we have a single study so far showing that if you give cisplatin-based chemotherapy with immune checkpoint blockade, that improves survival in the metastatic setting compared to chemotherapy alone. And then the combination of an antibody-drug conjugate with immune checkpoint blockade has really transformed the care of patients with metastatic urothelial cancer. And I'll show you some of that data. So here's the phase 3 EV302 study. This is enfortumab vedotin. This is an antibody-drug conjugate directed against Nectin-4, highly expressed on urothelial cancer. In fact, urothelial cancer has among the highest expression of this protein of any solid tumor. And that has a cytotoxic payload linked to it called MMAE, which is a microtubule agent, so delivering the chemotherapy more specifically to cancer cells. That drug was approved as a single agent several years ago for metastatic urothelial cancer. Then it was combined with immune checkpoint blockade in some smaller studies. The response rates were about 70%, higher than anything we've seen in metastatic urothelial cancer. That led to this phase 3 study. And so you can see this regimen compared to platinum-based chemotherapy sort of blows platinum-based chemotherapy out of the water, what we've been using for the past several decades. So this is now a standard treatment for metastatic urothelial cancer. Here's the data combining cisplatin-based chemotherapy with PD-1 blockade, immune checkpoint blockade, versus cisplatin-based chemotherapy alone, showing an improvement in survival, an improvement in progression-free survival, also approved as frontline treatment by the FDA for metastatic urothelial cancer. So we have 2 new regimens for frontline treatment of metastatic urothelial cancer, whereas we had nothing in decades approved in this space. So the progress that we're seeing in the non-muscle invasive disease space with new mechanisms, new drugs, new approvals, we're really seeing that across the whole spectrum of bladder cancer. This is an ongoing study, probably the last of the standard chemo plus IO studies in metastatic urothelial cancer to read out. This is a 3-arm study one arm testing the concept of giving 2 immunotherapies with standard chemotherapy. So we'll look forward to the results of this phase 3 NILE study. We already heard about genomic testing, and clearly important to do genomic testing in metastatic urothelial cancer because it is actually actionable in this setting, and I'll show you the reason that we do that. So erdafitinib, we've already heard about, given as part of the pretzel device instilled into the bladder, but this is actually an orally bioavailable drug, a pill that we use to treat metastatic urothelial cancer. It's a small molecule kinase inhibitor of the FGFR3 tyrosine kinase, and approved in 2019 based on a single-arm study that in patients with metastatic urothelial cancer whose tumors harbor this mutation, there's a response rate of about 40%. It's the only oral therapy that we use in metastatic urothelial cancer. Very different side effect profile compared to what we see with the other drugs that we use. Also seems to be quite non-cross resistant with other drugs. So patients progress on platinum-based chemotherapy, immune checkpoint blockade, still have a 40% likelihood of having a response to this small molecule inhibitor of FGFR3. In the metastatic, muscle-invasive metastatic setting, about 20% of patients have FGFR3 alterations. This phase 3 THOR study really sought to address both the comparison of erdafitinib, this pill, versus standard treatment, and also answer an important question at the time about sequencing of treatments. So after we gave frontline therapy, should we give this pill next, or should we give patients immunotherapy next? To make a long story short, if patients had both chemotherapy and immune checkpoint blockade, then erdafitinib was better than giving them some other chemotherapy, as you see in the blue curves here. The other actionable alteration that we now have in metastatic urothelial cancer is HER2. And HER2 is not tested based on DNA testing, although HER2 mutations actually are not uncommon in urothelial cancer. But this testing really refers to immunohistochemistry, protein level testing. You all know about HER2. You've been hearing about it for years in breast cancer, very prominent drug target in breast cancer. We know that in muscle-invasive metastatic urothelial cancer, HER2 overexpression, at least at the 1+ level, occurs in about 80% of individuals. And in the data that we've seen so far, there does seem to be some relationship between the amount of HER2 expression and the likelihood of responding to HER2-directed therapies. So this Destiny Pan-Tumor02 study tested an antibody drug conjugate. Again, one of these drugs, now an antibody directed against HER2 with a chemotherapy payload linked to it, tested this drug in patients who had received multiple prior chemotherapies in several different cohorts. So really testing what's become known as a tumor agnostic strategy. Doesn't matter what tumor type, if you have the target, maybe you could benefit from the treatment. And you see here circled that bladder cancer was included as a cohort. And you see in patients with bladder cancer, if the tumors had 3+ expression of HER2, there was a 56% response rate. Again, these are patients who had all standard therapies already and still had a 56% chance of responding to responding to this antibody drug conjugate. So this is approved by the FDA in a tumor agnostic fashion. Tumors with HER2 3+ expression or higher, including bladder cancer. So now we test all of our patients with bladder cancer for FGFR3 based on genomic testing and HER2 based on immunohistochemistry. The NCCN actually includes patients with 2+ expression levels as well, because in that Destiny Pan-Tumor02 study, the response rate was about 35%, 36% in that population of patients. We know that other HER2-based antibody drug conjugates are being combined with immune checkpoint blockade, just like that data that I showed you with EV plus immune checkpoint blockade. And we have 2 data sets so far showing response rates over 70%. And so these combinations of antibody drug conjugates plus immune checkpoint blockade are coming as the future for metastatic urothelial cancer. I suspect in the next couple of years, all of our patients will be receiving this type of strategy, potentially as a frontline treatment strategy. The ADCs keep coming. There's new ADCs with new targets, new payloads, new linkers all the time based on how effective these drugs have been. You know, this is the silver bullet concept that we all learned about in medical school, that there was going to be this sort of selective delivery of drugs specifically to tumor cells, and just the technology wasn't there. Now it's caught up. Now the linkers are the right linkers. The payloads are potent enough to kill cancer cells with very small amounts of drug. And we're seeing this translate into clinical practice. Here's one of the newer antibody drug conjugates, Dato-DXd. So this is directed against a protein called TROP2, again, very highly expressed on urothelial cancer, linked to a topoisomerase inhibitor payload. And you see in this cohort of patients with metastatic urothelial cancer, heavily pretreated responses in about 1/3 of patients. All of these drugs have different side effect profiles than we're used to, just like as Urologists are needing to learn about side effects of all of the new intravesical treatments. We've had to learn about how to manage all the different side effects of these systemic therapies, engage our specialists when needed. So ophthalmologists we've become very reliant on, dermatologists we've become reliant on based on the side effect profile of erdafitinib, based on the side effect profile of the antibody drug conjugates. Again, Beacon, critically important resource, particularly for clinical trials. If anyone's had a patient or other experience trying to find a trial for someone and going on clinicaltrials.gov, it's impossible to navigate because you get trials in another country. And so to really hone in on the trials that might be relevant to an individual patient, it's really important to have a disease-specific resource. So, Sia, I'll turn it back to you.
Okay, well, not a whole lot of time to discuss this last case. I think we covered a lot. I just want to get to some quick questions from the audience. We have a question from Dr. Sadeghi asking about muscle-invasive bladder cancer, patient undergoing cystectomy for neoadjuvant chemotherapy. Would you recommend EV Pembro in the neoadjuvant setting or Gemcis Durva? We haven't seen the data yet for EV Pembro in the neoadjuvant setting, so for now it's not an approved therapy, so we await results there. And then there's another question about ADCs in non-muscle invasive bladder cancer, and we know that that's under investigation. EV, enfortumab is intravesical therapy is under investigation in phase 1 trial. We've seen some preliminary data, but I think more data to come. I think with that, I'm going to move on to the Q&A session. Well, not a whole lot of time for Q&A. I think we answered some of those questions, and a tremendous effort by our panelists here. So if you can click to see if you've won, and if whoever the winner is, you can see one of the staff members in the back. So in keeping with time, I really want to thank our panelists. It was a tremendous overview of bladder cancer, what's to come, and look forward to hearing from our panelists again as they do some of these studies and bring forth the further information for bladder cancer. Thank you to the audience for your participation. Thank you.